David Sayen is Senior Vice President of Client Relations at Gorman Health Group. In his role, David guides GHG clients in developing strategies to respond to rapidly changing federal program opportunities. David recently joined GHG after a distinguished career at the Centers for Medicare and Medicaid Services, most recently as the administrator of the San Francisco Regional Office. He is continuing his focus on the western states, especially California, Arizona, Hawaii, and Nevada, using his extensive network of relationships in the industry there. David's extensive and in-depth knowledge of Medicare, Medicaid, and the Affordable Care Act marketplace regulatory requirements are an asset to GHG clients, and he has a particular passion around new payment models like accountable care, value-based purchasing, and comprehensive primary care. David earned his MBA in Health Administration from Temple University in Philadelphia and lives in the San Francisco Bay Area with his family. So please welcome David Sayen.
Well, good morning, everyone. There's certainly a lot going on, so a lot of things I'd like to cover this morning, so I'm going to jump right to it. Here I am. So, we're marching toward the promised land, and some of you recognize the promised land is going to be artificial intelligence taking over for healthcare, making our jobs a lot easier. For my bona fides, I know a little bit about computers. When I started with the government, we had one of these things, a data point, that you had to boot it up with cassettes in the morning. Still have one of the cassettes. And then we used it to collect data about surveys of health facilities in a system that was created when Cap Weinberger was the secretary under President Nixon. It didn't work very well, but my first real job in the government was getting this thing to sort of work. And it sort of worked, and the company went out of business and we got better stuff. So, government's in a whole other place now. We never really had a president like this, although for me, it's a little bit like the beginning of the Reagan administration where everybody's kind of going nuts and they don't know what's going to happen. But I do think after last week, it's a little clearer now, and I think we can think of what the direction actually looks like. The president has said a lot of things about health care, like that the whole system is a disaster. Am I not loud enough? The day I'm not loud enough is a rare day, because my wife is constantly saying, shh. And I say, you don't understand, I'm like really big, and so it just comes out really loud. I can't help it. So I'm from the East Coast, from Philly, and I remember the Trump Taj Mahal, how exciting it was when it opened, and how kind of sad it was when it closed, and now it's just sitting there with birds pooping on it. And so you got to worry about what that kind of a business is for us. One of the things that we always tried to do at CMS was to be a predictable business partner for people that we worked with, our contractors, providers, and so forth. Stuff like not paying the guy that provided the pianos for the place isn't the way you create good business partnerships, so we'll see what happens. Now, the reason last week happened, I think, is because those members went home to their districts, like 6 Democrats or 6 Republicans in California who are in districts that went for Hillary, and they saw all these people with brickbats and signs saying, don't mess around with our health care. The fascinating thing is the deflection point where the Affordable Care Act, whatever that is, became more popular than not the Affordable Care Act was just a few weeks ago, because people finally discovered, oh, there's something in there for me, and maybe we shouldn't take it away. And the great majority of people either thought they shouldn't repeal it, or at least before they should repeal it, they should figure out something that they're going to do in the future rather than just sort of trimming it back, which is what they did. This, I think, is the most interesting of the statistics. I don't think most people really know what Medicaid or Medi-Cal even is, except that most people think it should cover putting mom in a nursing home, and they call me and they're all mad that the government isn't taking care of mom when Medicare wasn't designed to do that and mom's not poor enough to be on Medicaid. The reality is, I guess people think that it's out there and maybe it's going to be there for me someday, so let's not mess around with it. And that, unfortunately, is a sad truth. A lot of people think Medicaid is going to help them when it's not. And that's something you want to pay attention to. So the theme that is behind this for me goes back to many years ago. When I first worked for the government, I saw a lecture at the Leonard Davis Institute at Penn on the slippery slope to government health care. And just today in Kaiser Health News, there's an article about Gavin Newsom and his desire to have this single-payer health care in California. Hope springs eternal. I think it was actually in the New York Times. Well, one thing is for sure, over time, this is the government portion and the non-government portion, we see that healthcare costs are certainly going up. This chart goes through 2015, but the government share of it also continues to creep up. Affordable Care Act was a big piece of that. In my view, the underwriting of healthcare is not something that households can afford to do. And even purchasing the underwriting of healthcare is something that many households can't afford to do, which is why we have this subsidy scheme that we've done now to take California from 17 million to 7.5 million uninsured, which anyone would see as progress, I think, if they had a practical bent. But if you're opposed to this direction, that's a problem. The thing is, people often at events will talk to me about, well, we should just do what they do in Britain, and we should just do what they do in Italy. But those people forget that this isn't Britain or Italy, it's America. And comparing our performance on providing health care to our population to little countries like Germany and France and Italy is an invidious comparison. They're much smaller, they have a more homogeneous population, and they have a much more socialist bent than we do, being a country of a lot of people that came here because they were rugged individualists. On the other hand, if you think about countries that are as large or larger than the United States, like China, India, and Russia, they don't do such a great job of allocating health care across their population either. So I would submit that getting to a sort of universal coverage system in our particular country is a difficult thing to do. It doesn't amount to grasping or grabbing somebody else's approach, and as the president's discovered, it's complicated to do that because there's a lot involved. But I believe that this march is inevitable because I think because of the tools that we've invented, healthcare is more like indemnifying nuclear plants, earthquakes, and floods than it is like car insurance. Just can't make those machines go away. So thinking about value-based purchasing for this project, it actually really got started in the government when I became the regional administrator, so I spent a lot of time talking about it. But the idea goes back to the Clinton administration when Bruce Vladeck was the administrator and spoke a lot about this idea of value, and that we had to move away from just purchasing units of service, some of which may not really be providing the useful value that the taxpayers preserve. If you're in the Defense Department, you get a budget. Your job with that budget is to defend the United States from attackers. Or if you're in Homeland Security, your job is to prevent, bad things happening in terms of terrorism at home. And we decided at HCFA that our job wasn't just to pay people's medical bills, which is where we started out and really struggled to do for a long time, but rather to have more of a public health mission and for those beneficiaries that our program served, get better value for them, have their health status be better in some fashion. So the Medicare Modernization Act of 2003, which brought in the Medicare Part D benefit, which is definitely a great benefit to the health status of Medicare beneficiaries, was also a time soon after that we were demonstrating value-based approaches in physician practices around bundling payments in particular. In 2007, we launched the Physician Quality Reporting Initiative that paid originally a 1.5% bonus to doctors who would submit quality data. I think about 15% of doctors actually did that in the beginning. A lot of medical groups did. We began to not pay hospitals for costs related to things that were acquired in the hospital and should not have been. And in a little corner of the program, that was a really big corner for me, and California was a big part of it, we introduced competitive bidding in durable medical equipment and saved about 1/5 of that $6 billion a year that we spend on medical care And one of the 6 or 9 original sites was San Bernardino, Riverside. I spent a lot of time down there. That's a very positive story about healthcare reform that people don't talk about very much. So there are approaches that work, but one of the real problems I think for Medicare in particular is there's a different payment system for every service. So you have this competitive bidding for this, you have this bid program for prescription drugs, you have this really complicated fee-for-service system for hospitals, you have another program for doctors. Other people don't buy things that way, and that's part of the problem. Because we solve one piece of the puzzle at a time, we create these one-off things and create a program that's difficult to administer. So I thought I would check and see who's at CMS now to find out what they're thinking about it now. So I went online and looked at the organizational chart, and lo and behold, it's blank. There are no names on the organizational chart, nor is there a mission for the agency on the website, and all the stuff that was on the website is now in an archive of previous administrations. We do know that Seema Verma is the new administrator, and I think we have a name for the gentleman who's going to run the Medicaid shop, but there are a lot of other people that have to be named. And what this does is it freezes everything up. So my wife works for the city of Oakland. She runs the senior centers. She wants somebody to come next week and tell the aging commission there what the Medicare benefits are for this year. So I sent a note to one of the guys who used to work for me. Oh no, we can't go speak anywhere because there's nobody there to authorize it, and you don't want these people going out, God knows what they might say. So you see, until you fill all those boxes, everything just kind of stops. And people just do what they were doing and wait to be told what to do because they're bureaucrats, right? So this problem of not filling the jobs that has been happening is a very big problem for this administration. Somehow I think, even though the president knew he was going to win, not a lot of other people thought that, and I don't think they really put in some of the work that would normally be put in a transition, whereas the Democrats probably had their people at the gate ready to roll because they thought they were going to win. And staffing up an administration is a huge job. There's about 3,000 jobs you have to fill, and these are people that can really do great damage. And at the same time, some of those jobs have to be given to people that are loyalists, and so about a third of the people that come into those jobs don't know what they're doing. And that's the real challenge for the career people, because the way it works is, in these big blocks like Medicare and Medicaid and program integrity, there's a political and there's a deputy that's career. And that career deputy runs the thing, and the political goes out and gives talks and tries to push, the agenda. So all those deputies are sitting there without somebody to tell them what to do running these things now. So where is value-based purchasing now? There's a lot of programs. There's a hospital program we'll talk about. There's a program around hospital-acquired conditions still, and a lot of other pieces to that. The PQRI is still around and becoming something else. We're getting data and publishing it about resource use by doctors now, and we have programs in home health and ESRD, and we're encouraging the states to do a lot of things. So on the hospital side, back when Tom Scully was the administrator in the Bush days, at the time of the MMA, he made a little deal with the hospitals and said, if you want your bonus next year, you're going to have to submit some data about what you're doing to improve the quality of your business. And 99.9% of them did, and over time this thing has grown like Topsy to a program that this year puts about 7% of a hospital's revenue at risk for meeting a whole lot of targets in these 5 different areas. And what's happened over time is the experience of care quadrant has really grown a lot, and it's a very powerful piece of this that's a tremendous challenge for those of you that are in the hospital business, because it's really hard to move the needle on what people think about your institution. I've had people say to me, if I have an older physical plant, there's no way I'm going to get the points on this thing. Okay, sorry about that. I'll try that. And so this is now an important part of this. I worked on that survey that we developed about 15 years ago, both for health plans and hospitals, to determine what people's perceptions of the institutions were across all the institutions. There's nobody that's really situated like Medicare to do that, I would say. And when you pick up these magazines about the best doctors and the best hospitals, they're not really meaningful information. They ask doctors which is the best hospital, but the doctors usually only know about the hospitals where they practice. whereas we're asking across all of them, or the government is, it's valuable, and most of those articles are informed by that. And you also see we've grown a lot in 25% on efficiency and cost reduction. So these hospitals are on the hook for the total cost of care for people that they care for, beyond the episode that the hospital cares for, so the post-acute and things like that. And what I would submit to you is this exists, value-based purchasing exists because of the technological disruption of information technology that's happened in the course of my career. We couldn't have done that with the data point 2200, with the phone modem and the 10 megabyte disk that looked like a birthday cake. Couldn't do it, right? So now the fact that we have all this information, now we have to do things with it. And so we're collecting this information, we're doing these things, and it's letting us put a needle on things that we couldn't put it on before, and there's really no place to hide. And I would submit, as I go through this, you'll see the last holdout on this is the physicians themselves, who now too are going to come to account to the public about how much their patients cost and things like that, which is a very difficult thing to get to, and we're not quite there yet, and that may change a little bit. So, point being, these clinical care outcomes change every year, but over time, the process measures that are relatively easy to keep track of have diminished, and the more difficult things like patient satisfaction, like spending, are rising to the fore. And I would argue this is a fundamentally good thing. Probably more should be at risk, and it will be over time, but it's also a very complicated thing. And there's just no easy getting around that. And I would say that that's probably because what you're doing is really complicated and difficult. Saturday I replaced the bumper on my wife's Subaru, using YouTube, and I broke half the clips, but I got the darn thing on there. You can't get YouTube out and do, surgery. So it's a complicated thing that's being provided, and my hat's off to people that are running these institutions and making this happen, and those of you that manage the information that lets them do that. Because a lot of institutions don't know how they're doing day to day on this, and if they don't, how are they ever going to improve and figure out which employee or which department is where the problem is? So I said it's going to come home to the physicians, and this is where last year we passed a statute that ostensibly fixed the problem of physician payment. So when Medicare started, the program understood that doctors are not all the same, and some doctors get paid better than others. And so Medicare Part B paid based on the reasonable and customary charges of those doctors. So doctors aren't stupid. As soon as the program came along, they began to raise their charges, and the program got more expensive. And over periods of time, various things were done to put a brake on this. And then in the Reagan and Bush administrations, we changed the way we pay doctors, and every doctor is now paid the same for the same service in the same locality. And that's still true to this day. Really a remarkably socialistic program for a Republican administration. I would submit to you the Republicans then are different than the Republicans now. Different ways of thinking about things. So that was done, but the problem still remained that we had to think about exploding costs. Because once you give people a fixed price, their next move is to provide more services and more intense services as a way to increase their revenue, and that's what providers did. And so Congress, in its wisdom, created a program where the program would cut itself, right, the sustainable growth rate, that said if the overall cost goes up too much, then we'll cut the unit price of services to some level so that the overall spend for the taxpayers doesn't go up so much. And every time it became time to cut it, they said, well, let's delay cutting this. And over time, they kept delaying and delaying until the actual value of the services we're paying like 20% more than we should have under the formula. And because of this, every year, Congress would face a regularly scheduled hostage taking of a bill they had to pass to stop this terrible thing to happen, and it got more and more painful for the Congress. And so what they really did is agreed to get the monkey off their back by throwing that system out and buying a 2-year reprieve where the doctors would just get a 0.5% increase, and then rolling in a new program that really doesn't get started until 2019. And that program, under the law called MACRA, is this Medicare incentive-based payment system. So here we go again. Instead of buying individual services and capping how much we spend, now we're going to be really smart and buy the services that are valuable and good and not spend money on those that aren't, which is a pretty hard thing to do. And so this system that the folks at CMS now have to come up with, and they're certainly working hard on that, basically will, as we've done with the hospitals, provide a range of winning and losing depending on how you perform on the quality measures that used to be voluntary. So there's a theme here. This is how government programs work. First, you have a voluntary program where you get a bonus if you do something, and if you're smart, you get on the train and do it because it's going to become mandatory, and if you're not good at it, you're going to lose, and the people that started will do better. And if you look at the medical groups down in this part of the state, you find people that are a shining example of the whole country that know how to do this. But in a lot of the other parts of the country, especially the red parts, not so much do we have physicians in groups that are sophisticated about these things, which could create a great backlash when this program actually stands up. The performance year for these payment adjustments was supposed to be this year, and the payment adjustments wouldn't start till 2019. So they passed the law in 15 or 16, beginning of 16, and it doesn't really happen until 19, and the Congress has a 2-year term. What I think they did is just bought a little breathing room. It's not quite clear to me how this ends. But what we do know is the original regulation on MACRA under Obama was lightened up quite a bit from what it was originally going to look like. But this system is there, and all government programs have to have a complicated chart. I got drafted to work on Y2K in Baltimore, and one day I was walking through the rabbit warren of cubicles, and this person had this really complicated chart on her desk that worked for me. I said, can I see that? And what it was like what happens to a claim through the whole front end and the systems and all these various things in banks and everything, and it was really complicated. It was like the thing Arlen Specter showed to say that Hillary Care wasn't going to work. And they said, well, you can't show that to anybody. We don't anybody see that. But these things always leak out. So in this program, we have one of these if-then things. And of course, you being information professionals, you're comfortable with these charts. Not everybody has to be subjected to what Don Crane from CapG calls the tender mercies of MIPS. They have an option to sign up for another program and have an advanced payment model, like an accountable care organization. We'll talk about that. And that gets them off the hook for participating in this MIPS thing and gives them a 5% payment bonus. Think about that. If you have a group of like 200 doctors and you're in cardiology and you're doing a lot of Medicare and you're going to get 5% of your total revenue, that's huge. Government's not going to give that money out easily. No, they're not. Because in those other programs, you're going to be reporting even more things and you're going to have more complexity, all based on the idea that we can harness information technology to solve the problem of rising costs of medical care. I don't think that that hypothesis is true. I think we can harness information technology to make medical care better and more efficient, but we can't make it cheaper because the reason it's getting more expensive isn't because of waste, it isn't because people are older, it's because of innovation. So the wonderful thing that we're here celebrating in our Innovation Center and that Medicare has an Innovation Center about is actually the culprit. Jamie Robinson at Cal, who's a wonderful health economics professor, uses this image of the escalator that I really like. So new drugs are being invented, new procedures are being invented, new machines are being invented every day, and that creation is this inexorable upward movement. So here we are on the escalator, and now we decide to have prospective payment to save money on what we spend in hospitals. What happens is we take a step back on the escalator, but it's still moving. And now we're going to pay doctors differently, and we'll save a little money. We take a couple steps back, but we can't stop that engine of growth because our economy is built around that engine of growth. That's how it works. So innovation can be our friend, and it can be our enemy. At some point, we're going to have to really deal with this problem of how much do we want to spend on this stuff because we just can't afford all of it, I would argue. This program may or may not work, but the thing you can count on is it won't launch at the time it was supposed to launch because it's too hard. But the other thing I would say is, given the ashes of last week, the last thing there's going to be any appetite to do in the short run is take this apart. because this is a messy, complicated thing to deal with, and they got the doctors to buy off on this scheme. AMA was supportive of this. So in some fashion, this is going to have to happen. Mr. Ryan, in his original approach at this health reform business, really wanted to take on Medicare along the way, and then they carved that out of the AHCA, and he really wanted to take on Medicaid, and they couldn't get that done either because it's hard to agree about these big, expensive things. So this is something to really watch. As I pointed out again, you get a bonus if you can be in one of these other payment models that I'll talk about, but what you're giving up there is you're going to be at greater risk too. So that's the challenge of that. Accountable care organizations, big deal. When I got my job, I went back to Washington to see my friend, well, for other reasons, but I went to see my friend Bruce Freed, who was the director of the Office of Managed Care in the Clinton administration. He's a lobbyist for CAPG, he's a lawyer back there. And he said to me, Dave, remember this word, ACO. This is a big deal, and I'd never heard the word before. It's 2007 or so. And I said, oh, I'll write that down. And sure enough, as usual, Bruce was right. This did become a big deal. The reason it's a big deal is because of what John Madden said about Miller beer. It's got more taste, but it's less filling. What I mean by that is this. Medicare beneficiaries, most of them, the big spenders, are the people that have fee-for-service Medicare and the supplement, because they don't have any exposure at all to the cost of their health care. So they can go to 3 doctors a day, and the government will just pay for it. That's kind of a problem. But people in Medicare value that freedom of choice because they think, gee, someday I might get some weird cancer or some problem, and I'm going to need to go to Cedars or I'm going to need to go to Stanford, and I don't want to be in some HMO. I want to have that fee-for-service, and so they have that. It's kind of like when you're changing your clothes out for the season, you ought to ditch the summer things that you didn't wear this year because you didn't wear them, right? But we'll keep them because maybe I'll want it next year. Well, that's what fee-for-service is like. It's this thing in the back of the closet that not many people use, but as we know, people don't like to lose things. In fact, they like losing things a lot less than they dislike not getting things. That's behavioral economics. So what this does is you've got the benefit of a fee-for-service kind of a program because the patients aren't locked into a particular medical group or group of providers. These things are sort of voluntary because people were just ascribed to the group of doctors through the wonders of information technology, and it's like a little virtual HMO, except that it isn't. On the other side, in theory, the government gets some handle on costs because these physicians and other providers that join this organization and work together, they're working together to generate savings relative to a particular benchmark and share in those savings. Again, another thing through the magic of health information, we can know or bet for every Medicare beneficiary what they're going to cost next year. And for those of you that don't know it, every Medicare beneficiary has a number right over their head that's somewhere related to 1. They're either less than 1 or they're more than 1. And that's what gets multiplied by the premiums to their managed care plans if they're in managed care plans, or that's where these benchmarks are created based upon Medicare costs for these programs. So the Affordable Care Act did a very important thing that I don't think a soul would think of when you say this is Obamacare, which is create this new Medicare program in the law that's a permanent program, coordinated care. That is this program that's not pure fee-for-service, it's not pure capitation, it is, I submit to you, light beer, which was a great invention. And this thing has taken off like topsy, surprisingly, because not a lot of people have made money at it. But, as I said before, astute people that are working with the government, when they see the direction that it's going, they get going in that direction because they're going to have to be there whether they like it or not. And waiting can be a painful strategy. On the physician side, we see the docs, if you went by hair, those that are like grayer, are less likely to want to play this game, and they say, well, I'll just take my lumps, get paid less until I retire. But if you're a physician in your 30s or 40s, you got to think about the future. This is the future, so you get tied up with a group and find a way to play this game. So we're up to 800 and some of these things. I think 360,000 clinicians are in some form of ACO or something like it. And predictably, these things are clustered in places where there are a lot of people. Because just like Medicare Advantage, this takes advantage of making savings out of competition. There actually is competition in healthcare. That's why healthcare is cheaper in Los Angeles than it is in Fargo. Because in Fargo, if you only have one hospital, they can charge whatever they want. So the worst places for healthcare, the places where you can't get any savings, are these places where there aren't a lot of people and there aren't a lot of healthcare providers. And it's much more expensive to provide services in those places where you get a concentration of resources in these urban areas. It's easy to do this. So the data tells us that this works because the ACOs that do save money don't get any money unless they perform on quality metrics. So ostensibly, people are getting better care along the way. So that's a good thing. One of the last things I worked on at CMS is a kind of supercharged version of this with more risk and more managed care-like features in terms of you can actually sign people up, you can give people some incentives for signing up, a number of things like that, and we have a few of these here in California. Another approach to this alternative payment model that's been around for a long time is the idea of putting services together in a bundle and buy the whole thing. Now everybody here knows, I bought that bumper for my wife's Subaru on eBay, pretty good deal because it was painted already, much easier. But if I bought all the parts to make a Subaru in my driveway, it would be much more expensive than buying the new Subaru. So the point is the bundle of goods and services can be a more efficient way to purchase things. That's the way we buy most of the things that we buy. And so from the government's perspective, we experimented with these things going back to the 90s and consistently demonstrated, particularly in areas like orthopedics where you have a fairly predictable resource set and outcome, we could generate savings through this approach. And so as we got toward the end of the Obama administration, people started to get a little aggressive. This often happens because the people that are there know they're not going to be there, so they want to just do some stuff. And so they turned around and said, this is so great, we're going to make you do it. Here's another feature of the Affordable Care Act that no one would think of as being Obamacare because they doesn't know it exists, but it allows the secretary to change the Medicare program and benefits without statute if it's demonstrated that some approach that they've tried works. Does anybody know what the first service that Medicare covered under this provision was? Nobody knows this story. It's an interesting story. It's like an Oprah story. It was a YMCA program to counsel people about their weight. And it turns out that this inexpensive program, you get people into, it's kind of like a Weight Watchers Lite. You can start to make a dent in their health by impacting their weight, which is like probably the most significant healthcare cost thing we face other than innovation. And so Medicare pays for that program. That's a good thing. We need to do more things like that probably. But what they decided to do here was something a little less popular, which is to tell 66 localities around the country, one of which we're sitting in today, they told those hospitals, well, beginning next year, we're going to look at the total cost of the services you provide to people that have lower joints replaced, and we're going to set a benchmark, and if the total spend on those cases is greater, you're going to be at risk for some of that money. Now, we're not talking about the cost in the hospital, which is kind of fixed because Medicare pays fixed amounts anyway. No. We're talking about all the money Medicare will spend for that person. It's very difficult, if you're a hospital, to control what people do after they leave. And up until very recently, the idea of the hospital was do what you're doing to that person and get them out of there. In fact, the government encouraged that. That's what the whole DRG system was about, until we figured out that a lot of people crashed after they got out because maybe they lived in a shopping cart, or maybe they were pretty kind of unable to manage their meds and other things because they lived alone in a single-room occupancy hotel or any number of things like that. And they'd end up in the emergency room and spend a lot of money, and we didn't have anybody to tag with it in this disaggregated system. I mean, there's a reason why you see a propensity, particularly on the Republican side in Medicare, to go toward private health plans, because then there's somebody out there to say no and organize these things. But in fee-for-service, the whole design of it is that there's no organization there. So now the decision was made, well, we're going to make the hospitals do this. which is a very difficult thing to do because they really don't control these programs outside the hospital. But in the demonstration programs, some people did it pretty well. But like a lot of things in business, the early adopters are different than the mainstream folks and very different than the late adopters or the never adopters. And so providers are struggling with this. And in the beginning, there's a performance year where they would get data and see how they're doing, but now the rubber's starting to meet the road, and it creates a real challenge. But our friends in the Obama administration at the end of last year, even before this thing was proven, said, we need to double down on this. We're going to add broken femur, broken hip, and we're going to add cardiology bundles too, and we're going to stretch it out to 99 places. That proposed rule came out in like September. And one of the many predictions I was right about was that thing would get delayed, and it just got delayed last week, got pushed back like 6 weeks, and in the preamble to the interim rule that delayed it, they said, well, we're really thinking about delaying it to January. If you don't know about our new Secretary of Health and Human Services, Dr. Price, he's an orthopedist from Atlanta where they do things fee-for-service for the most part. And orthopedists do not like this mandatory bundling program at all. He's an outspoken critic of it. And some people think he will derail this thing. Well, if we have a secretary that thinks what we need to do is go back to 1965 and do the reimbursement that way, well, there's a problem with that scheme because we tried it and it didn't work. It worked from the physician's perspective, but didn't really work very well for everyone else. But there is a kind of belief, this is probably the Freedom Caucus and Rand Paul's belief, another physician turned politician, that we need to get back to people just being able to go to the doctors. That's what it is. They be able to afford to go to the doctor, they get their savings account, then if they need something expensive, they've got their health savings account to pay for it. Well, that's great, except that most of the things that heal us don't get done on a visit to the doctor. Right? The visit to the doctor is just the first part. And like in my program, I skip that part because it's usually an email to the doctor and then I'm off to the specialist or the lab. So medical care is very, very different than it was in '65. The economy is very different. This was a very bold approach, and I salute them for trying it. I just don't know if it's going to stick. But I think it's quite a remarkable stretch. And now we've just got an administration that's a very, very different focus. Another area that was a big focus in that data that I showed you about how we disincentivize or incentivize hospitals was focusing across the board on how many of the people that they serve end up getting admitted again in 30 days. And not just admitted to their hospital, just admitted somewhere. Now, our aunt had a heart valve job done, and they sent her home with these pills and all these things, and they sent somebody to the house to put in guardrails and all that, and we imported my brother-in-law who lives up in Tahoe to take care of the aunt. And I remember the first night, they're sitting there with those plastic things that say Monday, Tuesday, Wednesday, Thursday, arguing about which pill we should take or which one we shouldn't. I got a call in the middle of the night from a cell phone number and hung up on it, but it was actually some San Jose policeman who was taking her, in the ambulance, or fireman, to the emergency room, and in her blurred state, she blurted out my cell phone number, and he just called me on his, and that's how I found out. And it turned out she had been to the emergency room like 3 times after that admission. And she was a Kaiser patient, so Kaiser really probably hates it when their patients show up at somebody else's emergency room. But what are they really going to do? They got to work with the family that they have. You can put some guardrails in the house, and you can train them, but it's really hard to make this adherence work. And so that is another place where the government's trying to create some pressure to get somebody involved in figuring out what happens after people get services. And here's a place where there's a great opportunity for information technology. There's several vendors that are in this space that have built platforms that can tie together the hospital, the LTAC, the SNF, the home health, and give people a dashboard of where their patients are and how they're doing. Because you only need a couple of them to go bad, and then you lose on the whole program. And so there's an incentive here to force that, and I can only imagine how difficult that is to do, and I really respect the people that make it work. I've spoken to some of them, but the real reason these people crash oftentimes is things that are non-medical, right? It's just social issues around the community. So we did a project for Meals on Wheels, who seem to be out of favor today, but we did a project for them in Baltimore where they worked with a hospital and trained their volunteers when they brought food to the people who had just gotten out of the hospital. They made sure they were taking their medicine, they made sure they weren't eating salty takeout food, and they notified somebody if things didn't look right with the patient. Having somebody show up every day is a really good thing. Home health generally doesn't show up every day except maybe right in the beginning. So that's a pretty good program. I hope there are more of those programs. I'm doing some work around placing social impact bonds to support programs like that eventually can create savings. So big challenge there, managing what happens when people get out of the hospital, but we know that we're around 17% readmission now, but the best institutions that are around 10. But we were at 20, so across the board, since Berwick was at CMS, we made some real progress on this. I think we're going to make more progress. And if any of you have dealt with yourself or a relative, when the thing goes wrong and you got to do it over again, that just really, really stinks. It's just not a good thing to happen at all, so I'm glad that we're focusing on that. That's a good thing. Medicare Advantage, I'll close here, and this is another important place where the value-based purchasing approach is big. So when the government started contracting with HMOs in the 80s, it was just, you're going to get a capitation base, and good luck, you're going to save money. If you save money, you make money. We had no way of really knowing what was going on inside those organizations. Well, that's changed a lot. Now we have lots of information about what happens in MA. We have encounter data. We have surveys of what the members are doing. And with that, the government incentivizes those plans based upon their performance and how that performance rolls up into this program where they're reported as stars, like movie or restaurant ratings. And what we see is these star ratings, those plans that have 5 stars have very few people that they lose, less than 2%, whereas a 2-star plan is losing 20% of their people every year. Costs over $1,000 to get somebody into a Medicare Advantage plan. People in Medicare Advantage plans are mostly old and they die a lot, so it's a really difficult thing if you're losing people that are still alive. You don't want to do that. So that's a real challenge for the plans. And what we've seen, it's changed over time, but if we look at last year, the things that the plans continue to do poorly on are these really obvious things like reducing the risk of falling. Again, in the example of my aunt, they said, you know, she drove into the driveway and there were like 3 steps up into the house and there was no railing there. So it was pretty easy to put a railing there, a railing in the tub, but apparently a lot of health plans just don't bother to do that. Or things like monitoring physical activity. It's not that hard to do. I mean, I've got one of these little gadgets. You could give that to the members, maybe lock it on them so they can't take it off, and we know if they're moving around. I mean, there's ways to monitor people's physical activity. It's not that hard. In fact, I saw a wonderful presentation by a woman from the South Bay where they do a program in clinical trials where they use devices like Fitbit so that instead of just following the person like through the treatment, they can follow them for a year and see if they continue to be active and that kind of stuff. There's lots of possibility actually that can be done in this monitoring area. Another place where they do poorly is osteoporosis management in women that have bone issues. Everybody knows that this is an issue. We know the proper way to treat it. There's really no excuse for health plans to not do that correctly. But at the same time, there's some areas where the average is really high. They've got their complaints down, pain assessment is better, and they're doing better at managing the people that speak different languages. That's a good thing. But there's a lot of ratings where it's just kind of stuck, suggesting that maybe plans have gotten as good as they're going to get. And part of this has to do with maybe these are expensive things to do, but some of them I don't understand, like why we're averaging 3.4% on an eye exam for people with diabetes. Eye exams aren't that expensive. Health plans know who their members are that have diabetes, I hope. And it shouldn't be that hard of a thing to get better than a 3.4 on. So there's still challenges to face there. And we do a lot of work with plans around basically improving their stars. Because the stars mean money. Half a star is between $5 and $50 per member per month. If you've got 6 million members in your plan, like a big plan does, and you multiply that by $50 PMPM, that's a huge bonus. And plans bank on those stars going forward. If they lose them, it's a big deal. That's when they call us in and we help them get their program going so they can do better. So what's going to happen? That's what everybody wants to know. That's what business people want to know. There's not going to be another $33 billion program for your industry. I can tell you that right now. That was a lot of fun, but we're not going to do it again. And you know, while a lot of that was invested in things that are being ripped out, like the health information system at the hospital where my wife is on the board, a lot of it was invested in things that are working wonderfully, and you're all a big part of that. And because of that, this shift from volume to value, I would argue, will continue just because it's got its own momentum. Just like the Wall Street Journal today shows how like natural energy sources are going up and coal's going down, and despite the administration's trying to revive coal and put the coal miners back to work, it ain't coming back because it's dirty and it's expensive and it's just not the way to go. Sometimes there are real things in the world that you just can't legislate away, and this volume and value thing is part of that. I suggest that it is true, before we had government health care, when it was a thing that people bought out of their pockets, they probably got better value for it, but the nature of the thing is so different now that we can't go back there, so we need to go forward and do this value thing. And a good way to think about this is think about the automobile industry. You know, my kid is starting to drive now, and I'm remembering buying these cars that were like falling apart, driving them and getting another one. And I remember driver's ed saying, if the car has more than 50,000 miles on the clock, it's seen better days. And that today, a 50,000 mile car is like they sell it as if it was a new car. It's a great car because cars are dependable. They don't break unless your wife bumps into things and you have to replace the bumper. You know, that you get a really good value for them. I mean, you really do in terms of getting you places. It's going to start, you're going to get there, it's cheaper than it used to be, and it's safer, all these things. So why can't healthcare do that? Everything does that. Things improve over time, and that's what we're seeing happening. We're going to see more of these payment reforms. So the government reforms that I talked to you about today are reflected in the private sector too, and similar things started there. The government's not in a vacuum here, but the government has the advantage of being able to invest more in these things and being a bigger player so that they can drive the market. And that's the leadership that I think under Dr. Berwick and Marilyn Tavenner, we did that in a lot of ways. Medicaid is something to really watch. They failed at the regularly scheduled effort to turn Medicaid into a program that's got a fixed appropriation and a budget. It would be great if it had a budget so the federal government could get the monkey off its back and send it to the states. But some of you probably saw Governor Brown say that Trump should come out of his tower and see these people on the street, and it's not so easy to just cut them off. And that thing died as I expected it would. And nobody's really going to figure out how to solve this problem of the cost of Medicaid, which, as you probably know, here in California, it's a third of the people in our state, and it's more than half of the children that are born in our state. So it's a very important part of our healthcare system, and we can't just dump it very easily. So what I think we'll see with the new administrator is more flexibility for the states, particularly around letting them try these approaches where people have to have a job or work to be able to stay on Medicaid or try to get a job. I don't know how they're going to make that work. Nobody's really done it before. We tried it with welfare. It kind of worked, but medical care is a little different than welfare. If the person's sick, they can't work, so it's a chicken and egg. It's like, well, you got to get well and get a job so you can get health insurance, but you can't get well because you don't have health insurance. I don't know how that's supposed to work, but hopefully it'll work. I'm watching on that one. The Medicare Advantage part of Medicare, the people that are in private health plans, that continues to grow. It's at about a third now. It's about a half in Southern California. But as people age into Medicare, more and more they choose those plans because they're comfortable with that kind of medical service. And frankly, they don't really understand that the fee-for-service thing is this tremendous bonanza that they just aged into because they've never experienced anything like it. They didn't experience the old Blue Cross plans that were there when I was younger, where you could just get whatever you wanted. So that's changed a lot, and that's going to continue like that. And the consolidation of providers and health plans, the health plan side slowed down a little bit with the antitrust, but I do think that we'll continue to see that. I think that the healthcare industry probably could be more concentrated. If you look at the large investor-owned hospital systems, they're just more efficient. They get better results, they do it for less, and they manage to pay taxes too. And so the not-for-profit systems that are wasteful are going to have to get on the ball and do the same thing. And I think the way that they'll do that is through consolidation. And I think the focus on population health will continue. For many years, Senator Grassley from Iowa argued that these not-for-profit institutions that are in healthcare and get money from the government really ought to be doing things about the populations in the communities where they're located, not just the people that come to them for care. And we're beginning to see more of that, and a little bit of a shift toward the public health side because so many thinking people say our public health statistics are not anywhere near what they should be for the money that we spend on medical care programs in the United States. Maybe we need to spend a little bit more money on programs that keep and make people healthy and be more efficient about how we spend the money on the people that are sick and it's too late to prevent their problems, and we're seeing that. And the president does say that he's evolved on this issue. I imagine in the last 7 days he's evolved even more on the issue because now he wants to work with the Democrats. I think it'd be fascinating if he just throws the Republicans under the bus and now does something with the Democrats, which is quite possible because he seems to be pretty mad at those very conservative guys. He didn't think that they would really let him down like that. So we'll see what happens with that. So there we are, a little bit of everything, but the theme that I want to leave you with is this purchasing for value thing isn't going away because it's the only thing from the payer side that you can do to get any kind of handle on the costs. But from a social perspective, we've got to do a lot more than that to deal with and manage the cost problem as it's kind of eating up too much of our economy more than it should. And with that, I know I have a few minutes. I'd be happy to entertain any questions.